बहू का इंट्रोडक्शन देना जरा मुश्किल होता है.
She is the daughter-in-law of Professor Kamalji Singh. She is trained from Sadhguru Neer Chikitsalaya in medical and surgical retina. She is main interest of Victor retina surgery is especially the ROP. She is doing much work, in fact, if I am not wrong. I invite Dr. Smith Galan. Please carry on, please. Thank you.
Very good morning to all. It's an absolute pleasure to be here. And on behalf of AIOS, I would like to thank Dr. Shrikant sir and Dr. Kamaljeet sir for giving me this opportunity to present here. And today my topic is CRVO studies and protocol. So we know that we classify the retinal vein occlusion mainly into central retinal vein occlusion, central retinal vein occlusion, and branch retinal vein occlusion. And also clinically, CRVO is classified distinctly into two types. One is non-ischemic CRVO and one is ischemic CRVO. Coming to the incidence of CRVO, so non-ischemic CRVO, which is less severe, so this is the most common form of CRVO, around 80%, and 20% of them is the ischemic CRVO. About the pathogenesis of the central retinal vein occlusion, so we know that there is a thrombosis of central retinal vein at the lamina cribrosa that happens, which leads to the central retinal vein occlusions. And the various risk factors which are involved in the CRVO are the age, hypertension, diabetes mellitus, glaucoma, any hypercoagulable state, any medications like oral contraceptive pills or diuretics. These are the common risk factors. Coming to the features of non-ischemic CRVO versus ischemic CRVO, the non-ischemic CRVO can cause chronic macular edema, it can cause central scotoma, it can convert into ischemic CRVO, or it can further leads to, if the cilioretinal artery is present, it can lead to cilioretinal artery occlusion, and usually there is no ocular neovascularization present in the non-ischemic form. Coming to the ischemic CRVO, it leads to the neovascularization of the anterior segment. It can cause neovascular glaucoma. There are chances of vitreous hemorrhages, and it can also lead to optic nerve atrophy. So the conversion rate of non-ischemic CRVO to ischemic CRVO, it has been studied that if the age is around 45 to 64 years, the conversion rate is around 8%. With 18 months of follow-up, and same if the age is more than 65 years of rate, there is a higher conversion rate which is around 18%. So basically the age, if more than 65 years, there are higher chances of conversion of non-ischemic CRVO to ischemic CRVO. Coming to the management, the most important part to determine in the management is first to differentiate between ischemic CRVO from non-ischemic CRVO, because that totally changes our management and the prognosis also totally changes. So the first step is to basically differentiate between the ischemic and non-ischemic CRVO. So there are various comprehensive eye assessment that we do in the CRVO cases. So we do the morphological test and we do the functional test. So in the functional test, we do the visual acuity, we do the pupillary defect (RAPD), we also do the electroretinography, we do the visual fields. And coming to the morphological test, we do the ophthalmoscopy and angiography. Among them, the most reliable is the electroretinography, but electroretinography, if it is combined with the RAPD, it is most reliable among all these tests. And the least reliable is the clinically, that we do the ophthalmoscopy. So coming to the treatment, so we do basically, we can do the medical treatment, we can do the photocoagulation therapy, or we can go for a surgical treatment. So there are various clinical trials which, so there was the evolution of CRVO treatment strategies. So we started in 1995 with the laser therapy, which was told by CRVO trial. And and then now we have anti-VEGF, and now we also have the comparative between the different anti-VEGFs. Coming to the fourth study, which is the CRVO study, it was a multi-center randomized prospective control study. There was two questions that they have asked. One is the can photocoagulation decrease the neovascularization, and the second question was the does macular grid pattern decreases the vision loss from macular edema. Also, they did not do any intervention. They just followed the natural history of the patients. So the findings from the CRVO studies showed that there was a reduction of macular edema with macular grid laser, but there was no improvement in the visual acuity. Also, they have told that early PRP failed to reduce the risk of neovascularization of the iris. So macular, also they have said that the macular grid tend towards better visual acuity in the younger patients, and there was no improvement in the older patients, but it was clinically a non-significance. So the laser recommendation from CWAS that we got was treat neovascularization only after it develops and initiate PRP only once 2 clock hours of neovascularization have developed. Also, they have said that no laser is recommended for macular edema in CRVO. Coming to the second study, which is the SCORE study, which was based on the triamcinolone. They have done the standard care versus corticosteroid for retinal vein occlusion. So what they have done is they took the standard versus 1 mg IVT versus 4 mg IVT. Total number of patients was around 271, and their endpoint was percentage that gained 3 lines or more at 12 months, and they followed the patient for 36 months. So what CRVO studies have told that if we give 1 mg IVTA versus 4 mg IVTA, 1 mg group was almost 1 mg and 4 mg both have around 26% gain in 15 letters, whereas the observation group have only 7% gain letters. So what they have recommended is 1 mg IVT is better than observation. One more study on the steroid was the Ozudex, that is the Geneva study. In the Geneva study, they randomized the patient to 0.7 mg or 2.3 mg versus sham. So after 6 months, they have said that 0.3 mg or 0.7 mg both have around 41% gain in 15 letters in both the groups versus only 23% here in the sham group. Also, only the 3 patients needed glaucoma surgery in 0.7 mg group, whereas 30% required IOP medication. So IOP spike with Olurex occurred usually around 8 weeks, whereas the IOP spike with IVT around 34 days after injections. Then we come to the anti-VEGF, which is now the standard of care. One of the studies, the CRVO study, where it was they have done the ranibizumab 0.3 versus 0.5 versus observation, and their endpoint was the change for BCVA at baseline at 6 months. What they have said that 46 and 47% gain in 15 letters or more compared to 17% in sham group. Also, what they have said that the treated group gained an average of around 12.7 and 14.9 letters compared to the 0.8 letters in the sham group. Another study, so the CRVO study said that anti-VEGF is now the treatment of choice standard of care in the retinal vein occlusion, and the drawback was that there was we have to do the repeated injections, and also after stopping the anti-VEGF, they can still develop the neovascularization. One more study on anti-VEGF was the Galileo and Copernicus study. They have studied the intravitreal aflibercept 2 mg versus sham, and they have followed the patient till 6 months, and then further on PRP basis from 6 to 12 months in both the groups. And what they have said that there was an increase in around 50 to 60% gain 15 letters in the aflibercept group versus the sham group. Then there was one more study, which is the SCORE2 study. Now they have compared the effectiveness between the 2 bevacizumab and aflibercept group. So 2 anti-VEGF agents, bevacizumab 1.25 mg versus aflibercept 2 mg. They have injected the patient every 4 weeks, and the 6 months prior primary outcome was followed up, and visits ongoing through 5 years. So what they have concluded that conclusion was intravitreal bevacizumab was non-inferior to aflibercept with respect to visual acuity after 6 months of treatment. So we can also use the bevacizumab as an alternative because it is cost effective also. So this is that study has told. Compared to a new study which just happened in 2023, which is one faricimab. It was a Comino study. It was a phase 3 double mask clinical trial. What they have studied is the safety and efficacy of faricimab in comparison to aflibercept patient with macular edema secondary to CRVO. They have what they have told that 20 to 25% patients in each at 24 weeks in both the treatment arm, rapid vision gain and central retinal thickness with faricimab was non-inferior as compared to aflibercept. Also, they have said that there was in both the arms there was 20 to 25% of ocular adverse event were present, which was mild to moderate in severity. So overall, faricimab was well tolerated. Safety profile was comparable to aflibercept. So my take-home message was that perform PRP only after neovascularization develops and avoid lasers in the macular edema. We can use a 1 mg IVTA for CRVO macular edema. Dexamethasone implant can also be used to improve the vision, but we have to monitor the IOP. Also, anti-VEGF is now the standard of care, and there are various ongoing treatment which still going on the studies, and the recent study on faricimab trial has showed that there's a comparable efficacy of aflibercept for reducing the macular edema in CRVO. So these are my references.
Thank you.
Thank you.